We live?
Ma'am, we are live now.
Okay. Uh, Good evening, everyone. I'm Dr. Meenal, the Deputy Manager for the Gennova's Medical Advice. Today, this No Thrombosis National Workshop is basically for all the interesting cases that comes in the segment for stroke. So we'll be discussing all the interesting cases over here. So without any further delay, I would like to introduce our post director for today's session, uh, Dr. Shiv Kumar, sir. Dr. Shiv Kumar sir is senior consultant neurologist and epileptologist. He has done his BM from Trivandrum. He has also done his clinical epilepsy and EEG fellowship and also an international sleep disorder specialist. He is an HOD and senior consultant epileptologist and neurologist and also director at Purna Neuro Super Specialty Clinic and also senior consultant at Manipal Hospital. His expertise, Sir's expertise lies basically into epilepsy, sleep medicine, stroke, headache, and comprehensive epilepsy care, including epilepsy surgery. His key achievements lies in being a founder for Epilepsy Prevention and Integrated Care Initiative, also provides free epilepsy clinic and surgery support along with awareness program and seizures first aid education. He has been recognized for various contribution to epilepsy care, sleep medicine, and neurological education. He has various national and international papers and journal in his name and multiple neurology book chapters. He has been part of various national and international societies. With such a brief introduction, I would really like to invite and welcome our post director, Dr. Shiv Kumar, sir. Welcome,
thank you,
sir.
Dr. Meenal, for the kind introduction.
We will move to our first speaker, Dr. Shahana, ma'am. Dr. Shahana, ma'am, being a chief consultant neurologist at Clear Medi Multispecialty Hospital, Mysore. She has her expertise in neurological care with expertise across clinical neurology. She being a gold medalist over her medical graduate, undergraduate, postgraduate, super specialty courses and presented research at 27th World Congress on Parkinson's disease and related disorder in Prague in 2022. She has 10 publications in national and international journals and 3 textbook chapters on her name, part of multicentric gut microbiome and neurological disorder research papers. And she's been actively contributed to a neurological research and academic initiative while achieving evidence-based neurological practice. I welcome Dr. Shahana on board today for being the speaker for today's session. Welcome, ma'am.
Thank you, ma'am, for this introduction.
We have our second speaker for today's KT Live, Dr. Sonia Tambe, ma'am, who is a consultant neurologist and epileptologist, also has fellow of European Board of Neurology and advanced epilepsy training to the International League Against Epilepsy. Her expertise lies basically in adult and pediatric epilepsy, migraine, and neuromuscular disorder, cognitive disorder, vertigo, and neuroinflammatory diseases. Her achievements basically being a fellow of European Board of Neurology and completed advanced epilepsy training through, again, International League Against Epilepsy. She has been promoted advanced-based epilepsy care with evidence in advanced neurological management and also recognized for delivering patient-centric neurological care with a special focus on epilepsy and comprehensive neurological disorders. Dr. Sonia, ma'am, welcome for today's session.
Thank you.
Without further delay, I would like to hand over today's session to Dr. Shiv Kumar, sir, to set the context for the session, and then we can start with our cases.
Okay. Thank you, Dr. Meenal. I hope I'm audible.
Yes, sir, you're audible.
Yeah. So thank you, Gennova and the team here who has organized this fantastic programs for improving the stroke care for stroke, which is a very common problem in neurology across the world, and it is a big problem in our country. And through this platform, we have a lot of interaction with a lot of neurologists who present their cases. We discuss the cases and we try to see what is the best management which could have been done in this case during the presentation or maybe after that, which will help us learn something called as case by case basis. And so we have two very good doctors here, Dr. Sahana P and Dr. Sonia Tambe, who will be presenting the cases here. So let's see the cases and we will discuss. As I was telling you that stroke thrombolysis or acute stroke care is a big challenge. Most of the patients don't reach to us on time for thrombolysis, and many come with probably a wake-up stroke or maybe beyond the window period for the standard IV thrombolysis. And we have a lot of guidelines which are coming up where when someone comes beyond the window period, how do we tackle them and how do we manage them? And probably in the future, we might have more windows and more opportunities for tackling these patients who are not coming into the window period. And we know that every 30 seconds, one patient in India is suffering from stroke, and it is one of the leading cause of morbidity and the third cause of death in India after cancer and the coronary artery disease. So in my practice, what I see is that probably less than 20% of the people reach to us within the standard window period where we offer them IV thrombolysis. And of late, we are using only one antithrombolytic agent, that is tenecteplase, probably because of the data and the robust mechanism of action and the outcome what we have seen in the last few years. Earlier, we used to use Actelize, but now tenecteplase has become the standard default drug of choice for us to use in stroke thrombolysis. And complication wise, if I tell, we hardly see complications. We usually see some transformation of the infarcts into hemorrhagic transformation, probably after the thrombolysis, particularly in cases who have a lot of risk factors who have come little late into the thrombolysis, but which is manageable and it can be easily tackled with good knowledge. And so identifying the stroke at the onset by the relatives, good transportation to the hospital, what we call it a stroke ready hospital for stroke thrombolysis, and then identifying the right candidate for right thrombolysis will be the three key parameters where we can improve the stroke care in India. So with this brief context setting, I welcome the two doctors who will be presenting the cases here. Let's see from them and we learn from the case, and let's discuss what is the best thing what we could have done for this case in an ideal scenario. So I welcome the doctors and I ask them to present the cases here. Let's discuss the cases. Thank you very much.
Dr. Sahana, can we start with your presentation?
Sure.
You can share the slide.
Yeah, sure. So good evening, everybody. I hope I'm audible.
Yeah, ma'am, you're audible and the slides are visible.
Thank you. Good evening, everybody, and hello to Dr. Shivkumar sir and Dr. Sonia. Glad to be presenting this case in front of you all, the esteemed faculty. So this is one of my cases which put me under the spotlight because it was slightly tricky. So let me present my case. So it was a 55-year-old male who was a driver by occupation who presented with acute onset weakness of the left side associated with slurring of speech. He arrived at around 90 minutes of onset of his weakness. He was also on hypertensive with occasional consumption of alcohol. On arrival, his NIHS was around 6, BP was around 160 by 80, GRBS was 118 milligram percent. So we screened for the thrombolysis protocol. So he cleared it and we were getting ready to thrombolyze him after neuroimaging. So the neuroimaging was done, which showed there was no hemorrhage, so most likely to be an infarct. CT angio head and neck showed no large vessel obstruction. So we were getting ready to thrombolyze him with injection tenecteplase, 0.25 mg per kg. The clinical dynamo was while I was preparing to thrombolyze him, and just prior to thrombolysis, I just reassessed him. Luckily or unlucky, lucky for the patient, the deficits had completely resolved. His repeat NIHS was 0. Now, my dilemma was, should I give injection tenecteplase or should I not? What if I start him on antiplatelets and if he progresses, because then I cannot give him tenecteplase. If I do not give him, he may progress. If I give him, it may not be indicated. He can end up with an intracerebral hemorrhage. So this was the presentation of the patient. He had dysphasia. You can see that visibly the hand grip was weak. The power was around 3 by 5. And this was just prior to thrombolysis. where he completely recovered and in the emergency prior to thrombolysis, when I reassessed, the deficit had almost completely resolved. So then I went back to the guidelines. So the ASA-AHA guidelines 2019 recommends that if the patient has completely recovered before thrombolysis, that is NIHS is 0, you do not administer thrombolytic agents if the patient has no residual deficit or if it's a non-disabling deficit. So this is because of the risk of symptomatic intracranial hemorrhage. Though it is less, this risk is always there. So, but if the patient still has any disabling deficit, that is if the patient has reduced from NIHS 13 to maybe NIHS 7 or 6, even if the NIHS is low, you can go ahead with IV thrombolysis if otherwise eligible and within the treatment window. So, but also there is an important caveat, that is you look at the vascular imaging. So before deciding not to thrombolyze, it is important to determine whether there is a persistent large vessel occlusion, that is an ICA or a proximal MCA occlusion, which was not present in my patient. Now, if the CT angio shows a large vessel occlusion, there is a significant risk that the patient can deteriorate early, that is around 20 to 40%, depending on the occlusion site and the collaterals. These patients require close monitoring, permissive hypertension, avoid hypotension and dehydration. You keep the patient NPO initially till stability is confirmed. Keep the endovascular team aware of the patient. Proceed to rescue thrombectomy immediately if neurological deterioration occurs and the patient remains eligible with or without bridging thrombolysis, that is if he is within the 4.5 hours window period. And the landmark evidences were the PRISMS trial, which showed that minor not disabling stroke with no functional benefit of thrombolysis because they have higher symptomatic ICH risk. And also Tempo 2, which says that tenecteplase in minor stroke with occlusion, it's an ongoing study with no implications right now. The study is yet to be concluded. So now the decision framework depends on whether it's a disabling deficit. My patient had a disabling deficit and he recovered completely. Persistent LVO, no, my patient did not have any large vessel occlusion. Perfusion mismatch, unfortunately, we didn't have a perfusion imaging in our setup, so I could not comment on that. The bleeding risk would be definitely low in my patient. So if it was a significant deficit, I would have gone ahead with thrombolysis. And ultimately, it's a shared decision between the patient attenders and you. So in my case, my decision was to not thrombolyze the patient. My justification being that since there was no large vessel occlusion with no disability, NIHS being 0, the risk of progression, further progression was quite low. So I still monitored the patient closely. If he had deteriorated within the window period, my plan was for reperfusion therapy. So in this patient, I realized that the indication for thrombolysis is determined by the patient's neurological status immediately before the treatment, not by the maximum NIHS which was recorded at the time of admission. So in conclusion, I would like to say that rapid improvement does not generally imply benign outcome. NIHS may underestimate the disability and vessel imaging changes the management. So I would like to all of you to remember that treat disability, not just NIHS. Obtain CT angio whenever feasible, individualize thrombolysis decisions, and document shared decision making. So these are my references. Thank you.
Okay, Sahana. So you told that the patient recovered when you were about to thrombolyze.
Yes, sir.
And if CT was showing infarct, what would have been your decision?
So even if the CT had shown an infarct, if there was no large vessel occlusion, since the NIHS was 0, I would have still closely monitored him and not thrombolyzed because I didn't have an evidence to thrombolyze him then. But if there was a large vessel occlusion, it was more likely that he would have progressed. So if he had progressed, then yes, I would have gone for reperfusion therapy.
Okay, so this patient presented to you within 90 minutes of the symptoms.
Yes, yes, sir.
Okay, so you are closely monitoring this patient. You imagine the hypothetical situation. So at 4.5 hours to 5 hours, he develops another symptom. What do you do?
So then if there is LVO, then we have to refer him to a center which could do a mechanical
No, in your case, there is no LVO.
Yes. So then if it's out of window period, then again, it is just conservative management. So we will not be able to thrombolyze him.
Okay. So, anyone has any other questions? So this is what the difficulties is because we don't have evidence for every question what we see in clinical practice. So we had instances where we thrombolyzed the patient has recovered, and after 6 hours or 8 hours or 10 hours, the patient has got recurrence of symptoms in spite of thrombolysis. Second, we felt that there is a non-disabling stroke and we are not thrombolized. The patient will worsen after 4 or 5 hours after the stroke, where there is no LVO, there is no chance for you to do any thrombectomy or anything like that, and then you are nowhere. And then situations like this where MRI or CT shows an infarct, but there is no deficits. Again, we don't have clear-cut guidelines to say whether we can thrombolize the patient or not. So these are some of the caveats and where we have unknown, I mean, there is no standard answers for all these things, even with the experts across the world. So this is kind of a thing which is the best decision you have taken to the patient during that time holds still good for any patient. I don't think there is anything wrong in anyone taking any other decisions at this point of time.
Sir, I would like to add to this. Also, since NIHS is predominantly for the anterior circulation, there has also been instances where my patient, probably NIHS would have been 2 or 3 in a posterior circulation where there's a basilar artery thrombosis. In such cases, I've still gone ahead and thrombolized the patient because these patients are known to evolve and NIHS is not very good for a posterior circulation stroke. So a low NIHS in a posterior circulation stroke with a basilar artery thrombosis is still, I feel, an indication to thrombolize the patient.
No, you're right. Whenever there is a thrombus or any vessel disease which is seen on imaging, we would have thought of thrombolysis. But in your case, there is no imaging evidence of any occlusion or thrombosis, dissection, or nothing is seen in your case.
Not in this patient. I was generally talking about a posterior circulation stroke where there, even if the NIHS was less than 5, probably if there was a basilar artery thrombosis, I would have still gone ahead and thrombolized the patient, not following the regular guidelines. Here, since it was an anterior circulation with no LVO and NIHS of 0, I held myself back from thrombolizing this patient.
Okay. Did you do an MRI in this patient?
Yes, sir. MRI was done. There was a small lacular infarct, which was detected after 24 hours. I got an MRI stroke protocol done. I identified a small lacular infarct in the superficial cortical lobe.
You should have shared that images because when you present the cases, this is how you should present the cases because showing evidence is much more important than just saying it was there. So what we would have done is if the patient has improved, I would have quickly done an MRI immediately rather than waiting for 24 hours. I would have seen what is the core deficit, what is the infarct, whether there is still changes which are seen. Sometimes stroke mimics has to be ruled out in the first 24 hours if your CT is not picking up. So probably I would have quickly done the MR immediately after he has recovered just to confirm the diagnosis and be prepared myself mentally for the thing. So waiting for 24 hours would have not given you any advantage.
True.
How do you treat this patient?
This patient was just treated with antiplatelets, sir.
How do you treat this? Like, how do you treat with antiplatelets? You can tell the youngsters how do you treat with antiplatelets when you have a situation like this.
So initially we give loading doses of aspirin and clopidogrel, 325 and 300 mg stat with atorvastatin of 80 mg, followed by the next day you start him on dual antiplatelets with high dose statins for a duration of approximately 3 months. And then you can come down to single antiplatelets. Also screen for the ECG echo, look for any arrhythmias, and also look at the neck vessel Dopplers. Since here already CT angio was done, I had not got a Doppler done.
Okay. What are the risk factors for someone to have stroke very early when we identify in the workup? So can you tell the youngsters some of the risk factors? If you see in this patient, you will be prepared or you will be thinking of aggressive treatment in these cases. What are some of the parameters?
Especially whether they are above 60 or below 60. So if they are above 60, age itself becomes a risk factor, male gender becomes a risk factor. Look for the lipid profiles, look for hypertriglyceridemia, hypercholesterolemias. Also look for whether they're alcoholics or smokers. They again tend to have arterial diseases. Less than 60 years, look for vasculitis kind of disorders so you'll have to do an ANA, RA factor, Pianka, Cianca. Do a serology. Sometimes HIV can present as a stroke. Also look at HbA1cs to see if they're sugars because they may be non-diabetic, maybe a newly detected diabetes. Look at the RBS, random blood sugars, HbA1cs to see if they have any, if they are on borderline diabetics. So all these need to be ruled out and addressed accordingly if depending on their age factors.
Was it a lacunar infarct in your case, like a hypertensive lacunar infarct?
Yes.
Okay. So his BP was 160 by 90, if I'm right, in a slide what you presented.
Yes.
So how do you manage the BP in the first 24 hours? Tell the youngsters, how do you manage it?
So depends on whether you're planning to thrombolize the patient or no. So if you're thrombolizing the patient, the ideal the BP that you target will be around 185 and less than 110 within the first 24 hours, and after that less than 180 by 190. 180 by 90. So in this patient, I prefer to have a slightly higher blood pressure because, so not in this patient, but generally if you have a large vessel obstruction, you tend to have a high, slightly about 140 to 160 is permissible hypertension is what we say. So because hypotension can again cause an evolving infarct. So in this patient, my target was around 140 and somewhere around that, not too low or too high. Since there was no large vessel obstruction. So initially, I just started him on oral antihypertensives. If his blood pressure was beyond 180, 190, probably I would have given him a stat dose of labetalol, which was not indicated in this patient, just managed with oral antihypertensives.
So you will continue his antihypertensives, what he is taking, or you will hold it for first 24 hours?
He was not on any antihypertensive. In the sense, he was a little defaulter, he used to take on and off. So in him, I started him on a low dose antihypertensive, which was continued. And since his blood pressure, that is, I started him on cilnidipine 10 mg. With 100, he was maintaining a blood pressure 140 by 90 all throughout the 3 to 4 days of admission. So that was continued thereafter and on follow-up.
Now, when do you start? Do you start within 24 hours? You start beyond 24 hours?
So it depends. So since this patient didn't have any large vessel obstruction, I started him immediately on antihypertensives. If there was a large vessel obstruction, I would have gone slow because I would require a blood pressure of around 160/90, which was good for me. Since it was not there, I wanted a targeted blood pressure of 140/90. So I started him immediately on an antihypertensive.
Okay. So you do a CT angio as a stroke protocol. So tell the young neurologist here what and all you cover to look for the stroke risk stratification and find out the mechanism of stroke. So how do you go ahead with the stroke protocol CT? What and all you cover in that?
Yes, sir. So again, that depends on the age, less than 60 or more than 60. So if you're doing it for a patient less than 60, it's always better to cover the arch of the aorta as well. So because sometimes an thrombosis there can trigger stroke in these patients. So you look at the arch of the aorta, look for beading, which could be a sign of vasculitis in a patient less than 60 years of age. In a patient more than 60 years of age, you're basically looking for large vessel occlusion, which is just the proximal internal carotid artery and the middle cerebral artery, the M1 and the M2 segments. Because if there is thrombosis in these regions, you can always go for mechanical thrombectomy in a center which has a facility. And also look for collaterals. If there are good collaterals, that means to say that the perfusion is good. Poor collaterals, and the patient has a higher risk of evolving into a evolved infarct. So these are some things that you tend to see on a CT angio. Also look if there are any features of arterial dissections, aortic dissections, arterial dissections, any, like I told you, beading for vasculitis. So these are some of the things that we really look into in a patient with stroke.
Okay. So you imagine a hypothetical situation. This patient is already on dual antiplatelets and he comes to you with stroke. How do you manage?
So first of all, you need to know whether the patient was compliant with the dual antiepileptics or is a drug defaulter. So a drug defaulter coming with a stroke doesn't make him resistant to antiplatelets. So if he was he was correctly taking his antiplatelets and then he has ended up with a stroke, first, you need to know whether it is a cardiac embolic stroke so that you can switch him over to a newer oral anticoagulant. Second, if not, you'll have to think of ecosprin or clopidogrel resistance, which you can check for through the blood test. And if they are resistant, accordingly, you shift them over to either newer oral anticoagulants or you can go with other newer antiplatelets.
Okay. Thank you, Sana. That was a nice session.
Thank you.
And so let's move on to the next case presentation by Dr. Sonia.
Sir, can I share my screen?
Please share your screen.
Yes. Is my screen visible?
It is visible.
Yes. Yeah, so I'm Dr. Sonia Tambe. I'm practicing in Fortis, Banerghata Road. Today's case is not about decision about thrombolysis, but it's an interesting case of subsequent management and decision and diagnostic treatment dilemmas. So I'm presenting case of 30 years old gentleman, no prior comorbidities. He presented with sudden episode of forgetfulness and confusion. He was supposed to pick his kid up from school, and then he forgot to do that in the afternoon around 3:30, and then his wife started getting calls. So she picked up and then she brought him to our hospital. So the exact onset we did not know. And apart from that, he was having history of on and off numbness in left half of the body since 15 days. Family noticed when his wife noticed when he saw her, and when he called him, he was not answering properly. He was talking irrelevantly. So he was rushed to our emergency. There was no history of fever, travel, seizures, or any other symptoms. The only other significant past history was multiple joint pains and fingertip paresthesias that he has been having since childhood, and he has consulted multiple doctors for that on and off pregabalin he was on. No diabetes, no hypertension, no dyslipidemia, and no cardiac risk factors, and he was a non-smoker. And on examination, he was confused. His short-term memory was impaired, and rest of the examination was normal. So his NIHSS, because of the confused and then he was not able to answer, it scored around 2. The orientation component of the NIHSS was abnormal. It was around 2 NIHSS. But he was outside of window period. So when we did his MRI, bang, we saw a acute stroke in left mesial temporal lobe, which was, corresponding with history, and he was having this acute onset memory loss. His MR angiogram was normal. And apart from this, what we saw was these other small vessel changes, like one in thalamus, one in internal capsule, one in this already was showing flare changes, and multiple other like insula on one region, operculum in one region, and then deep white matter also. So this was showing multiple infarcts of various ages. So it was either multifocal vasculopathy or cardioembolic. So that was our differential when we saw him. So because he was outside of window period, we started him on dual antiplatelet and some neuroprotective agents. And he was worked up very much in detail because of the history of joint pains and then fingertip paresthesias. Extensively, he was evaluated. His blood pressure at the time of admission was normal, sugar was normal, cholesterol was normal, B12 homocysteine, serology was negative, all the cardiac workup was negative, autoimmune workup was negative, thrombophilia panel was also negative, APLA was negative, sickling test was negative. We even did his CSF, which showed lymphocytic pleocytosis. Rheumatology opinion was taken, and all of us felt that it was most likely a case of systemic and CNS systemic vasculitis involving and causing small vessel stroke. We did vessel wall imaging also, which was reported as CNS vasculitis. Unfortunately, that CD is corrupted and I could not get those images. Because of so many history and then such prolonged history and then workup being completely negative, we decided to do whole exome sequencing in him. And surprisingly, we found a pathogenic variant of mutation in alpha galactosidase. So that was, he was positive for Fabry's disease. So it was all fitting. So small vessel, small fiber neuropathy since childhood, and recurrent stroke and small vessel stroke of multiple ages in the MRI. So we labeled him as Fabry's disease, causing stroke in young and small fiber neuropathy. So when to suspect, though we found this, he did not have any of these specific, probably the joint pains and then small fiber neuropathy, it took us towards systemic vasculitis. However, in any other patient with stroke, when to suspect Fabry's diseases, if they have peripheral neuropathy, cardiac involvement and renal involvement. So any patient with peripheral neuropathy, cardiac and renal involvement, one of the differential that has to be kept is Fabry's disease. The other things that, though our patient, we examined him very much in detail, angiokeratomas is something that is seen on the skin, mainly on the chest. The other finding Fabry's disease patient have in CNS is dolichoectasia of basilar artery. So if we have a middle-aged male presenting with stroke and then has dolichoectasia of basilar artery, one of the things that has to be suspected is Fabry's disease. And other CNS finding, though our patient did not have it, is pulvinar sign. So on T1, there is hyperintensity of pulvinar nucleus in both the thalamus. So these are some of the points in which are, if these points are present, one has to suspect Fabry's disease. And then just in brief about Fabry's disease, it's an X-linked lysosomal storage disorder. And it happens due to deficiency of alpha-galactosidase. And the deficiency leads, and obviously it is seen more common in males. And it causes neurovascular complications like strokes in very young age. The pathophysiology happens due to buildup of globotriacyl ceramide in the vascular endothelium, sometimes in mesothelium also. So the buildup of these lysosomal components leads to endothelial dysfunction, production of reactive oxygen species and prothrombotic state, because of which patients develop recurrent stroke. So this patient, we started him on antiplatelet for a very long time. And in between, he kept coming to us with history of recurrent episodes of impairment of memory and on and off numbness of right hand or left hand. And MRI did show some evolution of smaller strokes. However, we kept contemplating whether it is worthwhile to give steroids to him, because even though it is a genetic condition, so there are some genetically mediated vasculitis like DADA mutation in which steroids and then immunomodulators are recommended. However, in him, we kept contemplating, we had open discussion with the patient party. However, because of the side effects of the steroids and then immunomodulation, they decided that they want to, as of now, wait, and they did not want to go for immunomodulation. So we treated him with antiplatelets and AC inhibitors, even though he is not antihypertensives. In this endothelial dysfunction, what happens is when there is endothelial dysfunction, there is production of AC enzyme, and that increases the level of angiotensin. So giving AC inhibitors in such patients is very useful. And we took geneticist opinion for him, and then who recommended that this patient will benefit with enzyme replacement therapy. The only center in Bangalore that gives enzyme replacement therapy is Indira Gandhi, and then we got in touch with them. We referred the patient to geneticist at Indira Gandhi Institute. However, this was the first case of Fabry's, adult onset Fabry's, and till now for adults, they have not given any enzyme replacement therapy. So the cost was coming exorbitantly high, even if they wanted to give the treatment. And then the geneticist said that giving ERT may not stop stroke in him because it happens at very much microcellular level. So enzyme replacement therapy will be considered when there is cardiac involvement or renal involvement. So that is the state. Though we have a patient who is worked up and has a nice all the findings of Fabry's disease, we are struggling to give him enzyme replacement therapy, and the family has accepted that once in a while he might have small minor strokes, and that has to be managed with lifestyle changes like giving omega-3 fatty acid, AC inhibitors, antiplatelet, not smoking, maintaining sugar, cholesterol, and such things. And he undergoes cardiac renal evaluation every 6 months. Whenever there is involvement, an ERT will be considered. One NGO came in forward to give enzyme replacement therapy for 3 months, 6 months for him. However, what happens after that? That was the question of family. So that was also not taken. So this is the condition. And I want to ask the panel that is it, though it is a genetic condition, if the picture, the CNS shows evidence of vasculitis, if we do a biopsy, say meningovascular biopsy, if it shows vasculitis, how justified are we in giving immunomodulation treatment to this patient? Thank you.
Nice case, Dr. Sonia. So
Thank you, sir.
can you just go to the slide where you showed that he was diagnosed with vasculitis? So based on what evidence you diagnosed as vasculitis?
Yes, sir. So this vessel wall imaging was done. Unfortunately, the CD was corrupted. I do not have the findings. So there is enhancement of both medium and small vessels in him, and there was pachymeningeal enhancement that was present.
Okay, but that does that prove it is systemic vasculitis?
No, sir, it does not. It does not. He was extensively evaluated for all the vasculitis markers, ESR, CRP, everything was negative.
In one of your slides, you showed rheumatologist and then systemic vasculitis was confirmed. That's the
Yes.
reason I'm asking.
Yes, that was before we did the genetics. So after we did the genetics, just as we did the stroke in young workup, all the tests came negative. Rheumatology clinically opined because of the presence of this peripheral neuropathy picture, and he was having joint pains on and off a very long time. Before the genetics, as you know, genetic takes 1 month. When he was hospitalized, we had taken this opinion, and then he opined it as probable systemic vasculitis. There was no peripherally, there was nothing for us to take biopsy. So the only way we can prove CNS if there is any secondary vasculitis, though clinically it is Fabry's disease related recurrent stroke, we had given option to either empirically treat with immunomodulators to patient's wife. She refused it. The other thing that we have recommended is meningovascular biopsy to see if there is just the if there is just accumulation of this lysosomal storage, or there is presence coexistent inflammation that is present secondary to this Fabry's disease, and whether we can target that and treat the secondary vasculitis related stroke. Just how in CIDP, diabetes and CIDP overlap. So many patients, even with the diabetes, they have some evidence of infiltration of lymphocytes. And in such patients, we treat them with immunomodulation, and then they do respond. So whether that applies here in this particular patient. So there is no
that is only
literature
after you got the genetic diagnosis, you are thinking of all this. But initially, see, for a clinician who is working up this patient,
Yes,
and you have made a clinical diagnosis of systemic vasculitis. So
correct.
except for his joint pains, little bit of neuropathy, was there any markers of inflammation to say there is systemic vasculitis?
No, sir.
Okay,
No,
if
sir.
you would have
CSF
had systemic
pleocytosis was
vasculitis,
present. CSF
pardon?
lymphocytic pleocytosis was present, which can present in either.
That is very non-specific. What was the protein?
So protein was not elevated. Lymphocytes were fell.
So protein is not elevated, only lymphocytic does not give us any conclusion, because if I'm suspecting a CNS vasculitis, the most important marker in CSF will be a high protein.
Okay.
And not the lymphocytic pleocytosis. How much was the cells?
Cell for total swell, 12 only. All are lymphocytes, sir.
I mean, again, it is very difficult to say whether it is really abnormal or not.
Okay.
Why was DSA not done?
DSA in him. Okay, because there was no large vessel occlusion, and the vessel wall imaging had given us the answer, because there was nothing else additional that we were expecting to achieve by doing DSA.
See, gold standard for CNS vasculitis is?
Biopsy, sir. Meningovascular biopsy.
Then?
And then it is DSA. And in some
But
scenarios, vessel wall imaging also is now taking a role in patients with small, medium to small vessel, medium vessel vasculitis.
it only helps in large and medium vessels, if I'm right. It will not help in small vessel vasculitis. So you need a DSA.
Okay, sir. I'll recommend that.
Second,
Yeah.
why did you jump to genetic testing? What are the clues for you to say there was a genetic abnormality?
Yeah. In our hospital setting, all stroke in young, in which the preliminary workup comes negative, we do genetics, whole exome sequencing. So because of the recurrent stroke, and because we did not have any other answer, any other reason for this stroke, and then his joint pains, and then small fiber neuropathy, we did genetics in him.
Was a nerve biopsy or a nerve muscle biopsy would have helped you for vasculitis?
So in a nerve biopsy, sir?
Nerve muscle biopsy, because you are thinking that it could be a part of a systemic vasculitis.
Yes, a small vessel was a small vessel neuropathy. Surals were normal, sir, in him.
No. Before genetic testing,
Sir.
would you would have thought of doing some kind of a nerve muscle biopsy to see if there is any evidence of vasculitis?
Okay. No, we did not think about that because his NCS was normal, surals were preserved. And then even prior to biopsy, all the non-invasive tests as a standard we do. So even in so that is why we did a non-invasive test, which was genetics.
Okay. So his cardiac workup also did not show any kind of involvement in him.
It did not show, sir. It did not show any involvement. His ECG is normal. Currently he undergoes evaluation every 6 months for cardiac and renal involvement. So far there is no involvement, but then that is something that has to be kept in to picture. If involvement of that happens, only then enzyme replacement therapy will be provided.
Any family history was there?
No, sir. There was no family history. He was the first person in their family to get any of these symptoms.
So you told a statement saying there were recurrent strokes. Historically, there was only one stroke, if I am right.
Yes, sir. This was the presentation, and this is over past 1 year. He presented 2 more times, once with confusion, once with numbness of right hand.
No, this is after the genetic testing.
After
right?
the genetic testing, sir.
Before that, I am asking you what are the clues for us to look into this?
Because MRI itself was showing involvement of there was a stroke with diffusion changes. There was a stroke without diffusion changes. So this itself says that infarcts of various ages.
Okay. Transesophageal echo was done.
T echo was not done, sir. Bubble contrast echo was done.
So I would have first thought of something like a embolic source, like an infective endocarditis, or I would have worked up for transesophageal echo to look in a young patient for endocarditis.
Okay, sir. Because yes, sir.
So that will be required in a patient because genetic testing is the last resort.
Okay.
You will think of genetic testing only when you don't get any answers in the other investigations.
Okay. Okay, sir. He was not febrile, and infective endocarditis we did not consider. Maybe T echo now retrospectively, if they are willing now, I will recommend to them to see if it gives any additional findings.
Okay. Any other questions from the audience or anyone?
Currently, there are questions. We have a separate link to the audience, which is live streamed on YouTube, which is why you cannot see it here. But there are no questions from the audience end as well, as of now.
Okay. So I think from our side, we have discussed this. Anything from the organizers? Anything they want to conclude or they want to?
Yes. So for conclusion, I just want to say that both the cases that were presented today were absolutely phenomenal, and especially the type of panel interaction we had followed. So I think both the cases were really meaningful, and as guided by you, so we definitely we are sure that the audience will also definitely be benefited by this. So I would just like to thank all the moderators and also the speakers and Dr. Shiv Kumar for a valuable time. It really means a lot for us, especially after the busy work day. And we really look forward to collaborating with you going ahead for more such interesting cases. So thank you, Dr. Shiv Kumar, sir, Dr. Sahana ma'am, and Dr. Sonia.
Thank you. That was an excellent presentation by both the doctors. And I really enjoyed the presentation. So I thank the organizers and I thank the presenters. Thank you and good night.
Thank you, sir.
Thank you, Kumar, sir. Thank you, Dr. Sahana.
Just to mention the audience count, so we had almost 40 physicians and 40 HCPs rather across specialties, neuros and physicians put together who are a part of this session with us. So thank you so much, sir. And I'm sure all the 40 HCPs will definitely be benefited and have something to take out.
Thank you. Thank you.
Thank you.
Thank
Thank you. Take care. Bye.
Bye.
Thank you.
I'm ending now.